Hello everyone, I'm Dr. James Wu. I'm an assistant professor of surgery here at UCLA, and I'm also a member of the UCLA Endocrine Center as an endocrine surgeon. Thanks a lot for joining us today. I'm going to be talking to you about active surveillance of thyroid cancer. While you're following us along, if you have any questions, please go ahead and tweet to us with the hashtag UCLAMDChat with any questions, or you can leave a comment on the YouTube as well. All right, so here's a quick summary of what we're going to be talking about today. We're going to be talking briefly about thyroid gland and thyroid nodules, thyroid cancer, active surveillance at UCLA, and also the results of active surveillance programs worldwide. So let's begin with thyroid and thyroid nodules. The thyroid gland is a gland that regulates your body's metabolism through hormones it secretes. It lives in the lower part of your neck, right in the middle. And there's really three parts: the right lobe, the left lobe, and a little bridge called the isthmus. Behind the thyroid gland are four small parathyroid glands that regulate your body's calcium. So what are thyroid nodules? The thyroid gland can grow little lumps or bumps that we refer to as thyroid nodules. These are growths of normal thyroid tissue that have collected into a small ball. There are different types. Some make excess thyroid hormone, just like the rest of the thyroid gland. If it makes too much hormone, we refer to that as a hot nodule. If it is a lump of tissue that does not make hormone and is non-functional, we call that a cold nodule. It's an important distinction we make because typically nodules that make a lot of excess hormone, or those hot nodules, have a very, very low risk of cancer. And then sometimes these nodules can also fill up with fluid that is normally present in the thyroid gland, and sometimes we refer to those as cysts. And you can see that sometimes the thyroid can form a single nodule that lives in one of the halves of the thyroid, and sometimes people can develop goiters, or this diffuse enlargement of the thyroid gland with many nodules on both sides. Now, thyroid nodules are very common. And we say this because we don't want our audience who may suspect they have one or be found to have a thyroid nodule to be nervous about their diagnosis. Now, in the whole population, if we were to carefully examine everyone, 6% of women will be found to have a thyroid nodule that's big enough to see or feel, and 1.5% of men. If we were to use our ultrasound, which can detect even smaller nodules that we can't see or feel, we find it in a lot of people. We find it in up to 72% of women in some studies and up to 41% of men. So very common to find these. And despite how common thyroid nodules are, they very rarely contain thyroid cancer. And to that same point, it's so rare for a thyroid nodule to contain a thyroid cancer that we actually recommend against if you're feeling asymptomatic and you're feeling normal. There is no need to seek out a thyroid ultrasound to look to see whether you have a thyroid nodule. The United States Preventative Services Task Force looked at this question to see if we ultrasounded everyone to look for thyroid nodules, just to rule out thyroid cancer, does that actually help the population? And what they decided was that if you go on to biopsy and test and work up thyroid nodules, the chances of having an actual cancer are so low, we actually do more harm by screening and biopsying than the good we would do by picking up a few extra cancers. So let's say you visit your primary care doctor and they examine your neck and they do find that you have a nodule. So what's the next steps? The first thing they always do is we get a blood test. We are looking for something called the TSH, or the thyroid stimulating hormone. Again, with my first slide, we want to know if that nodule is making too much hormone, if it's a hot nodule. And that TSH test will tell us if it's hot or cold. After that, we always routinely order a neck ultrasound. And then at that point, it's best for you to see a specialist, either an endocrinologist or an endocrine surgeon, both of which are at the UCLA Endocrine Center. Once you arrive to the UCLA Endocrine Center, then the specialist will help you determine, based on the blood test and the neck ultrasound, whether this nodule has a risk of cancer or not, and whether it should be biopsied to try to confirm the presence of cancer or confirm that it's a benign nodule. And typically, we only recommend a biopsy if the TSH and thyroid function tests are normal, if on ultrasound it looks suspicious and doesn't look like a normal benign thyroid nodule, and also only if it's a larger nodule greater than 1 centimeter in size, or if it's located in a position that endangers other nearby structures. So inevitably, in some patients, we do find a thyroid cancer, even though it's rare to find those in a thyroid nodule. So let's talk about thyroid cancer and its management. There are many types of thyroid cancer, but predominantly, the most common type is papillary thyroid cancer, and that comprises 85% of the cases of thyroid cancer that we have. The other types are listed here. They have a different profile than papillary thyroid cancer, and for right now, they're less well understood. So because of that, we currently do not consider these types of thyroid cancer as candidates for observation. So for today's talk, which really focuses on the option of active surveillance for thyroid cancer, really we're only focusing on patients with a diagnosis of papillary thyroid cancer. If you have another one of these subtypes, active surveillance is just not a good option yet. So let's move forward with just talking about papillary thyroid cancer. Now, the treatment for papillary thyroid cancer used to be only one of these two options. We remove it with surgery, and we can either remove half of the thyroid, called a thyroid lobectomy, the side of which the cancer is on, or in some cases, we recommend that we remove the entire thyroid. But now, active surveillance is a new third option of how we manage these papillary thyroid cancers. And some of you might ask, well, if there is already a good treatment, a treatment that gets rid of the cancer, why are we even looking for another option of how to treat it? Well, this is why. Because with experience and by watching some of these cancers, we as an international community of thyroid specialists have learned that small thyroid cancers can either grow very, very slowly or simply not grow at all if we watch them over time. And that has led us to the understanding that for many of the small cancers that we can detect, that patients cannot see or feel, and we're simply finding on ultrasound, that we are over-treating them. We are doing too much surgery, too aggressive of surgery, giving too much radioactive iodine, and we're learning that for these low-risk small cancers, that less is probably more. And the reason for that is because the risk of surgery, even though thyroid surgery is relatively low risk, the risks are not zero. There's a 5 to 7% chance of temporary hoarseness. There's a 0.5% chance of permanent hoarseness and voice changes after thyroid surgery. And then if you have half your thyroid removed, there is a 13 to 50% risk, depending on which study you look at, that you would still need to take a daily thyroid hormone supplement because the remaining parts of your thyroid are simply not making enough thyroid hormone. And certainly, if you have your entire thyroid gland removed, there's a 100% chance that you would need to take daily supplement. If we simply watch tumors that are not growing or growing very slowly and avoid an operation, we can reduce these risks to nearly zero. And so when we are deciding what is best for the patient, is it active surveillance, lobectomy, total thyroidectomy, we consider three major factors. We look at the patient, we look at the tumor, and we also take a look at ourselves and the medical team that is surrounding the patient. So in terms of the patient, we look to see what their age is. If you are an older patient and there may not be as much opportunity for the thyroid cancer to grow over time, it is very different than a 25-year-old woman who is going to be looking at a lifetime of surveillance and regular visits. We look at the patient's anxiety level, and that really comes from two different sides. Some patients have a lot of anxiety about undergoing surgery. whereas other patients may have a lot of anxiety knowing that there is a biopsy-proven cancer in their thyroid gland, despite the fact that we know that its growth is relatively indolent. And then finally, we have to look at the patient's ability to follow up. If they travel frequently, if they are frequently out of town or live in a rural area without good access to medical care, then we may think that surgery and taking care of the problem is better than requiring the patient to follow regularly. We also look at the tumor. We are more comfortable watching smaller tumors. We look at the location. We want to make sure that these tumors are not located in a position where they, even if they grow a little bit, they may be pressing on other important structures that are nearby. And finally, we look at the medical team. We want to make sure that whoever is surveilling patients with thyroid cancer has to have a lot of experience with the disease, and also we also need to have good experience with neck ultrasound, because neck ultrasound is the key to how active surveillance works. And we'll talk about that a little bit more in just a second. Let me go through some examples of patients that we see in our decision-making process of what is best therapy for them. And in our first example, it's a 65-year-old woman, small thyroid cancer that's only 1 centimeter in size, and she's really nervous about undergoing surgery. In this type of patient, active surveillance is probably the ideal choice, even though a thyroid lobectomy or half the thyroid is appropriate. Compare that to a slightly younger woman, a slightly larger thyroid cancer that is destroying the capsule, meaning that it's pushing a little bit outside of the thyroid gland, and also she lives quite a bit of ways away from UCLA and has a difficult time coming back regularly for follow-up. In this patient, even though she would be a candidate for active surveillance and watching the tumor, there are many factors that contribute to a thyroid lobectomy being a better choice. And in this patient, we'd probably say that is the ideal treatment, although active surveillance is still appropriate. And finally, if there's a 56-year-old man with a large thyroid cancer, 4 centimeters, then we cannot do these less aggressive measures and would simply recommend a total thyroidectomy. So it's not that active surveillance is for everyone, it's about the right therapy for the right patient and the right tumor characteristics. So let's talk a little bit more about what exactly is active surveillance and what does that mean? Well, to break it down, it very simply means regular follow-up with regular neck ultrasounds. First, we do it every 6 months just to get a better understanding of what the growth of the tumor is actually like. And then if the nodule is stable, then we can actually decrease the frequency of ultrasounds after that. And that couples with a physical exam in the office. During this time, we also need to get blood tests because we need to keep the thyroid stimulating hormone level low. Thyroid stimulating hormone, it's in the name, its purpose is to stimulate the thyroid to make more hormone when the body feels like it does not have enough thyroid hormone. And that hormone can make the thyroid gland grow bigger, and because nodules are made of normal thyroid tissue, it can also make the thyroid nodule and thyroid cancers grow bigger. So we try to keep the level of thyroid stimulating hormone low, and the way we do that is with regular blood tests, and the endocrinologist may place you on a little bit of thyroid hormone supplementation. And finally, with these neck ultrasounds, we get a calculation of the tumor's volume, and we model that change over time. And I'll show you what that looks like. So you come in for the ultrasound, and you can see here, this is just an example of what a patient's numbers may look like. We keep this record of all patients who are undergoing active surveillance. We write the date of the ultrasound, and this modeled patient, her first one was in 2004. 6 months later, we repeat it, and you can see that we take 3 measurements of the width, the length, and the depth of the nodule. And there can be minor fluctuations over time, but we chart each measurement according to each ultrasound. What that generates for us is this plot in the same, we plot all the data points over time, and that shows us the velocity of the growth. And I'll show you the results of worldwide active surveillance programs in just a second, but 70% of these small thyroid cancers, and when I say small, I mean cancers less than 1.5 centimeters in size, are stable over time and don't demonstrate any real growth. This allows us to give you an additional piece of information, which is we calculate the doubling time. If the tumor continues to follow this curve of growth, how long would it take for this 1 centimeter tumor to become a 2 centimeter tumor? And in this simulated patient, at the current rate, it would take another 27 years for it to become 2 centimeters. So if it was a 60-year-old woman, she would be 86 by the time it was 2 centimeters. And about 20 to 25% of these tumors that we watch, they do grow, but they grow slowly and predictably. This is an example of what that may look like. As we get routine ultrasounds, it increases a little bit by little bit, year to year, and then again calculates this rate of growth, and it gives us a doubling time of about 4 years. And so this is why we strongly consider age, because in an 80-year-old woman, it'll double to 2 centimeters when she's 84, but if the patient is 20 or 30 years old, we know that we'll be looking at a surgery sooner than later. And finally, I wanted to emphasize that the goal of active surveillance is to maintain the patient's highest quality of life and minimize harm. We want to give the patient the right therapy for the right tumor. And so with this in mind, patients can choose to have surgery at any time. If the patient decides that the surveillance that we're doing is too cumbersome or is no longer possible because of changed life circumstances, or if the patient goes home and feels that they cannot stop thinking about the thyroid cancer in their neck, at any time we honor patients' wishes and can move on to surgery if needed, if that ends up giving the patient the highest quality of life. Otherwise, there are also other hard stops to where we say we also should do surgery. And that's if the volume of the tumor increases by 50% in 3 years. From experience, we know that happens to about 8 to 15% of patients. And then also, if the tumor spreads outside the thyroid gland or into one of the nearby lymph nodes, that happens very rarely, 0.5% of the time. And again, at any time, the patients can request to stop surveillance and move on to surgery. So is it safe? And this is where I want to show you the results of active surveillance programs worldwide. So here is a scientific report generated at Memorial Sloan Kettering in New York. And they watched approximately 280 plus patients with small thyroid cancers over the course of 5 years. In this first chart, this shows how many patients had their thyroid cancer grow more than 3 millimeters in size. You can see that as they watch it at 3 years, only about 4% of total patients had it grow 3 millimeters. And by the end of 5 years, a little over 10% had it grow 3 millimeters. That means for the remaining 80-some percent, it grew less than 3 millimeters in size. It probably stayed the same. When we talk about volume instead of the diameter, it looks a little different, but the story is roughly the same. Where about a quarter of patients at the end of 5 years of watching will have their volume increase beyond 50%. And then those patients, we typically may recommend a surgery at that point. This is the same data shown in a different way. This is all the patients. Each patient has a line going up or down. If the line goes up above 0, it means their tumor grew. If the line goes down below 0, it means their tumor shrank. So that in this small group of patients, about 7%, their tumor actually shrank as we were watching it. And this vast majority roughly stayed the same size. And then in this minority as well on the other side, they grew and later went on to a surgery. But this means that for these 280 patients, whereas if this was 1 decade ago, 2 decades ago, everyone would have gone to surgery, these 80% of patients were able to avoid a surgery and the complications that can come from a surgery. This is another experience out of Japan where this idea really was pioneered. And they looked at 2,000 total patients, 1,000 patients where they were watching and not operating, and then 1,000 patients they compared it to which they just operated on right away. And they showed that only 2% of the 1,000 people that they watched actually later underwent surgery because their tumor grew. Only 0.5% underwent surgery because they later found disease in the lymph node, which is where that number came from earlier. And despite this small number of patients having some disease go into the lymph node, they were still able to remove all the cancer with surgery. Nobody died because of thyroid cancer. Nobody had any thyroid cancer travel outside the neck to a distant site. And if you look at, compared to patients who went immediate surgery, even patients who underwent immediate surgery, a small percentage, 0.2%, still later had some thyroid cancer go to a lymph node. So even having surgery up front doesn't make that risk go to zero. And also, these are talking about the risks of surgery. 1.6% had permanently low calcium after the surgery. 0.2% were permanently hoarse. Again, those numbers are very low because thyroid surgery is safe. But if we do surgery on people who don't need it, we're subjecting them to a very low level of risk for not a good reason. And finally, 2/3 of these patients went on to require a daily pill for extra thyroid hormone. Last little study that I want to talk to you about, this is out of Korea. It shows you very much the same thing in the American and Japanese experiences, where 14% had their tumor grow, 70% had no change in the size, and 17% actually had their tumor shrink. And what I really want to direct your eye to is here in the increasing group. So when we're measuring tumor volume, and the upper number here is 10 to the 3, that's still the size of about a green pea or the eraser head of a pencil. That means that as all these tumors that increase in size didn't go beyond that size when it was increasing when they were watching it. So even though there is growth over time, it's not explosive growth, it's predictable, and as long as we're watching it closely, there are no bad outcomes so far from these 3 international experiences of active surveillance. So we do believe that this program is safe. So just to summarize, active surveillance, it's a safe alternative to surgery with patients with papillary thyroid cancer, and only that type. And it has to be, for right now, less than 1.5 centimeters in size. And what it involves is quite simply regular ultrasound, physical exams, blood tests, and we chart the tumor growth over time. So that concludes our presentation for today. If you want more information, we have our website for the Endocrine Center listed here. We have patient stories, frequently asked questions about thyroid and thyroid cancer, as well as links to all our other endocrine surgery webinars. If you'd like to visit us in person or have an in-office consultation, this is the line to call. These are some of the other webinars that our endocrine surgery group has produced and really relevant to our topic, and they can be found again on our website or on YouTube. So again, if you have any questions now, please tweet it to us with this hashtag or comment on YouTube. So with that, let me go ahead and take some questions here. Okay, so the first question we have is, how curable is thyroid cancer? The answer is it's very curable with surgery, or as I've discussed today, with active surveillance. Again, some of these things depend on the type of thyroid cancer that we're dealing with. The most common types, papillary thyroid cancer, the outcomes are fantastic as long as the disease is contained within the thyroid gland and the lymph nodes of the neck. And the cure rates for patients who are under 55 years of age, as long as it's still within the neck, goes to the 85% range at the end of 10 years. When patients are over 55, the outcomes are still great, but just a little bit less than that. The second question we have is, what types of food should you avoid when you're on radioactive iodine medication? So this is a little bit the opposite spectrum of the topic from today, which is when patients have larger tumors that may have spread outside the thyroid gland or have a lot of thyroid cancer that has traveled to the lymph nodes. After thyroid surgery, we do give radioactive iodine as a secondary treatment to get rid of the microscopic thyroid cancer cells that still may be sitting either in the bed where the thyroid cancer was or in the lymph nodes in the area. With regards to the foods, you don't want to take in foods that are high in iodine because they will interfere with the radioactive labeled iodine that you're given. I think that this question is probably best addressed when you talk to your endocrinologist when you're actively receiving radioactive iodine. We can feel free to call our UCLA Endocrine Center if you'd like additional guidance. And we have many informational pamphlets and flyers to give you about foods that may contain added iodine. The next question we have is, what evaluations are in place to determine treatment is working for hyperthyroidism? Well, so for hyperthyroidism, that's when we're talking about when the thyroid gland or sometimes a thyroid nodule is making too much thyroid hormone. With regard to that, the best test of that is the test we kept talking about, which is TSH, the thyroid stimulating hormone. Whenever there's any abnormality of the thyroid, that's usually our first go-to test to tell if patients are having problems with too much thyroid hormone, too little, or they have just the right amount. Beyond that, I would defer to the endocrinologist who's taking care of the patients for hyperthyroidism, because there's many different causes and many different treatments for those different causes of having high thyroid hormone. Another question is, when surgery is necessary or more effective than active surveillance long term? So I think that's a question that is really important, and I think we should revisit even though we addressed it a little bit during the session. So when we're watching the cancer, again, I showed how we chart the growth over time. Typically, our hard stop is if the tumor volume increases by 50%. At that time, we say that's probably enough and we should move on to surgery. There are other times where we would recommend surgery, and that's if the tumor is close to other nearby structures we find are important. But I think the more important message from today is that very few of these nodules grow. And if they grow slowly and predictably. So if they do grow, then surgery is a very excellent option, has low risk, and we're able to effectively remove the tumor. But the important thing is that that can always be saved for a later time, and we'll never get to a point where surgery is no longer an option because we've been watching the thyroid cancer with active surveillance. Let's see what other questions we have. Finally, I have a lump in my neck. Is that something I should worry about? I'm afraid to go to an endocrinologist. Can I check with my primary care physician? So if you do have a lump in the neck, again, at the top of our talk, we talked about thyroid nodules are very common in the population. So just because you feel a little lump somewhere in your neck is not a major concern for high anxiety or concern. There's a variety of things it may be, from lymph node to thyroid to other things. So I think the very first visit is appropriate to find your primary care physician, and they should be able to do an in-office physical exam, talk to you about your symptoms, and help you monitor it over time. What I would recommend against is just because you have a feeling of something to immediately jump to asking for or seeking out a neck ultrasound. Because again, like we said, if you ultrasounded everyone, you're going to find nodules in the majority of people. And that's going to lead to biopsies, more ultrasounds, more testing that usually doesn't lead to a cancer diagnosis. And there can be side effects and other costs associated with all that testing that are net negative for the population. So I think seeing a primary care physician when you have a lump in your neck is the first way to go, and not jump to a neck ultrasound unless your primary care physician feels like it's indicated. And then finally, is thyroid issues connected to facial palsy? The thyroid gland rests relatively low in the neck, down here below the Adam's apple, right in the middle. Facial palsies really talk about the function of the facial nerve. The facial nerve exits just below your ear and travels through your salivary gland, the parotid gland on the side of your face. The two are actually very far apart, and so anatomically they should not be related. All right, so I think this is all the questions that we collected through our session today. Thanks a lot for joining us. Be sure to leave any additional questions or comments. If there are other topics you'd like us to cover in future webinars, you can leave those suggestions as well, and that may be the topic of our next webinar we have next time. So thanks a lot, and I'll see you again soon.